Write it down.
Okay, so for next week, on Monday, all of us are going to our well elder. If you're going to Adult Day Healthcare, to, what's the name of the place? VIP, you wear a uniform. If you're going to the Irvine Senior Center or to the Oasis Senior Center, you wear professional attire. Okay, street clothes. Those restrictions are no jeans, no t-shirts, no athletic shoes, nothing revealing, closed shoes, professional attire.
No tie?
No what?
No tie?
You don't have to have a tie. No, no tie. Just like you would go maybe to an office where you don't have to wear a tie. Yes.
Do we still wear our hair up?
No, if you're not in uniform, you don't have to wear your hair up. So you can do whatever you like with your hair. It can touch your collar. All of us, all of you, I should say, will go to simulation as well. And your clinical instructor should have given you a heads up as to who's going when and where. Yeah? All of you know. For simulation, you have to wear your nursing uniform. So if you're going between your clinical and street clothes, you have to come back to simulation. I talked to Maria, and the reason they require a uniform is because you're simulating patient care, so you wouldn't come in street clothes to provide patient care. But if you just bring your top, if you just wear your top, just put it over whatever you've got on, that's good enough for simulation, so that you don't have to bring an extra set of clothes if you start with your uniform or have to change out in the middle of the day. So is that good enough? All of you need to have a name tag wherever you're going. Okay, don't forget to bring the paperwork with you to your well elder. The well elder packet, you have to do the interview. You have to come up with 3 separate nursing diagnoses based on the interview that you have with your participant in the senior center. A biological, a knowledge deficit, and a detailed teaching plan. So those are the 3 things you have to have. 3 nursing diagnoses. The instructions aren't all that clear on that, I don't think.
What the last one detail?
The detail, like if you have a knowledge deficit that the patient doesn't need education about their diabetes because the patient stated. So you would always have knowledge deficit related to the topic you're going to teach, as evidenced by a patient state she doesn't know how to do blood glucose testing. Then you would do like a nursing diagnosis about just diabetes teaching. But your detailed teaching plan, the other component, the step-by-step, would be one of those things. It's one thing. So to teach how to do blood glucose testing, you know, teach your patient to press the finger, get the lancet out, poke towards the side of the finger, put the drop of blood on the test strip, put it in the machine, read it. That's a step-by-step. So it's just one topic that you do a step-by-step teaching on. If you have someone who's coming in and walking with a walker, you could teach how to walk with a walker in your IGGI book on step-by-step how to teach. Whatever it is. So you have 2 nursing diagnoses, a biological, which may be a risk for, because they're healthy in many cases, and a teaching, a knowledge deficit just in general teaching, and then a detailed teaching plan. Okay? Any other questions about well elder? Okay. There's no end to the fun and games, right? And the assignments. Okay, I think I've finished with this, did I not? Yeah. The next one is, we're going to talk a little bit about oxygen therapy. So if you're going to give oxygen, first of all, it's a drug, and you must get a physician's order. I mentioned yesterday you may initiate O2 therapy without having an order, but once you have the patient settled in, raise the head of the bed up, started the O2. If there is no order, you need to obtain an order for O2. Oxygen can be harmful at high, like really high percentages. for a long period of time. So it's called oxygen toxicity. It can be toxic over a period of time at high levels. When we're administering oxygen, there are a number of options that we have, and this lists all the different kinds. We're going to look at each one of them, starting with a nasal cannula. If you're going to administer O2, we generally start with the nasal cannula. Why do you think we start with the nasal cannula?
Yeah.
Why not put a mask on them?
More comfortable?
It's more comfortable. The patient can still eat and talk. It's hard to hear what they're saying through a mask. So usually our first option is to provide the patient with a nasal cannula. A nasal cannula delivers between 22 and 44% O2. Now, how much O2 are you breathing in this room here at sea level? 21%. So usually, as a rule of thumb, I think they make it 20. And then every liter of O2 is 4%. So 5 liters of O2, 5 times 4 is 20, right? Plus the room air, so you're getting 40% of O2. Flow rates greater than 6 liters per minute should be humidified because oxygen is very, very drying to the mucous membrane. It's very drying. And generally, we don't run it that high for a nasal cannula. How do you determine how much to give the patient?
Depending on how low they're tapping.
Yes, based on their
O2 saturation.
O2 saturation, yes. And the pulse oximetry, we call it. O2 sat, the peripheral concentration of O2 in their capillaries. Okay, so if you have a patient with a nasal cannula, pay attention to the top of their ears where the cannula goes over the top of the ears. It's very, very likely that over a prolonged period of time that skin could break down. So sometimes you'll actually see a little 2x2 gauze or a Band-Aid or something. They'll put it over the ear to prevent skin breakdown from continuous pressure against that earlobe. Earlobe, top of the ear. You also have to check the cheeks to make sure it's not so tight that it causes pressure. Sometimes patients have so much edema that you can actually see the outline of the tubing in their cheeks. So pay attention to skin care when you are using a nasal cannula. So easy to apply. Every now and then, you'll come in and the nasal cannula has 2 prongs, one for each nostril. Sometimes it's sort of cockeyed halfway on their cheek. I've seen patients who have it in their mouth. It's kind of like, well, would you like me to fix that for you and put it in your nose? No, I'll just keep it in my mouth. I breathe through my mouth more than through my nose. However, oxygen is heavier than air. It would certainly drop down to be able to mouth breathers. They would get some benefit from that O2. You agree with that?
Well, sometimes you need nasal tracheal suction.
Put it in their mouth. It looks kind of funny sometimes when the patient's just kind of like, why are you having that in your mouth? So that's the reason. Okay, and then there are other mechanisms of oxygen delivery as well. That nasal cannula, usually we're going about, on average, it's probably 2 to 4 liters. Okay, and if you have a patient who needs more than what can be delivered through a nasal cannula for whatever reason, we may next then apply a simple mask. A simple mask can deliver 6 to 10 liters of O2. This one says 5 to 8. It depends on what book you read. 5 to 8, 6 to 10. I would never ask you a question that would be so close that you would miss it by a liter, so don't worry about that. The simple face mask is easy to apply as well. You need to, if the patient is dependent on the O2 per mask and they get a meal, or if they're going to get up to walk to the bathroom, you may need portable O2 in the room, but generally you put the bedside commode next to the bed and that's not an issue. However, if they're continually on a face mask and they have to eat a meal, you need to take the face mask off and then apply a nasal cannula while they're eating, because often they will desaturate, or the O2 saturation will drop below the level that we want to maintain. And during eating, they need to have continuous O2 as well. So you need to put the nasal cannula on. The next one that's listed is the Venturi mask. The Venturi mask is this one right here. The Venturi mask is adjustable. You can get a very, very accurate liter flow. You can dial in the liters per minute on that mask. So you can monitor very carefully the FiO2, the oxygen saturation level at which you need to maintain that patient's level of oxygenation. It's a Venturi mask. It's considered sort of high flow. Some books say 24 to 60%. Again, books vary on how much they give, how much they will administer. Flow rate can be 3 to 10 liters. And again, it's the mask that provides the most accurate oxygen delivery, Venturi mask. On the Venturi mask, the air is sucked through the side port. You can see the side port on that mask. And they should always be open. Okay. The partial rebreather mask is a mask that delivers 60 to 90% O2 at 6 to 10 liters per minute. You set the flow rate so that the bag that's attached to the mask, this one here, so for the partial rebreather, that bag remains 2/3 full. Okay? Make sure that there aren't any kinks or anything so that there's free flow of air. On the partial rebreather, that has that bag collects some of the patient's exhaled air, so that actually the patient rebreathes some of the air that's been exhaled. It just collects in that plastic bag. So overall, the patient rebreathes about 1/3 of their own exhaled air. And then there's the non-rebreather mask. You can get up to 100% O2. On the non-rebreather mask, it's the highest oxygen concentration deliverable by a mask in a spontaneously breathing patient. So the patient has to be able to breathe on their own. It has 2 one-way valves that prevent the air from, prevent the patient's air from being exhaled through the vent. Is that right? Let me think. Yes. So it prevents the patient from rebreathing the exhaled air, which it does for the partial rebreather. The reservoir bag is filled with oxygen, and the exhaled air escapes through the side vent. If you have a patient who's on a non-rebreather mask, on the non-rebreather, again, check to see how tight it is so that the patient isn't uncomfortable. They have to be fairly tight to be effective. Check the skin around the mask. And again, if they're on a mask and they need to eat a meal, make sure that you give them the nasal cannula. Okay. Oxygen delivery is ordered by the physician, and we give only low flow for COPD patients, although a lot of research has been done, and COPD patients are so complicated in what some of the underlying disease process is, other complicating factors, that some of this is, I think, probably our research. We'll probably be teaching the same type of thing 3 or 4 years from now. But what your book still says is that you never give them more. The rule of thumb is more than 3 liters of O2 per minute. And the reason for that is if you have COPD, you have chronic obstructive pulmonary disease like emphysema, your alveoli are distended, they're not elastic, they don't respond anymore, so they're essentially, if you can picture all these alveoli that are enlarged, not very responsive to not much elasticity in them, so they sort of stay full with stale air. You just picture that. So if you have a patient who has COPD, they have consistently very, very high CO2 levels. That air that is trapped is high in CO2. Okay? So those patients who have COPD, their respiratory drive is a dropping oxygen level. Okay? So understand this concept. If you have COPD, you have lungs full of stale air, very high CO2 levels, much higher than normal. So their stimulus to breathe, normally for us, is a rising CO2 level. Well, they always have a high CO2 level, so that's not their stimulus to breathe anymore. So on those COPD patients, their stimulus to breathe is a dropping oxygen level. There's a test question on this, and I tried to make it as clear as I can, and believe it or not, I never get more than 50% of the students to answer correctly, this concept here. So for COPD, their impulse to breathe is dropping O2 levels. For you and I, normally, the impulse to breathe is a rising CO2 level.
So when they get too much oxygen in COPD, that tells the brain to shut off their breathing.
Yeah, so if they get, the theory is, if they get too much O2, their O2 level doesn't drop low enough to stimulate their breathing. However, I've seen patients getting very high levels of, for like 6 liters, double of what's recommended for COPD, and they didn't stop breathing. But that's still how we teach it.
You know, they used to really think that like a lot of COPDers were retainers, and now they're thinking under 5%, so they're starting to teach it off of the oxygen's one of the few things we can give that, you know, so why starve someone of oxygen?
And I've seen them go at 10 liters and not stop breathing. But that's still how it's being taught, because and I think, like I said, the research now is beginning to show that we will probably rethink what their mechanism is for breathing. So this is still in your book about COPD, to limit it to 3 liters. That's still how the NCLEX exam asks the question. So for now, we'll leave it at 3 liters, ideally, routinely. 2 to 3 is usually what we say as a standard for COPD. They're not going to stop breathing and be apneic if you increase it a little bit. Just watch your patients. I've had lots of COPD patients, and like I said, they didn't go into respiratory arrest, and there's a lot of research going on.
Can we say that their drive to keep breathing is high in CO2?
No, their drive to breathe is dropping O2 levels. So the theory was, if you give them O2 at higher levels, it knocks out their stimulus to breathe, because they're used to an O2 level that's dropped to a certain level. So then you give supplemental O2, and that level is not reached, so the brain does not feel a need to stimulate the patient to take a breath.
They used to call it like hypoxic drive, right?
Right. So, yes.
Can you also clarify hypo and hyperventilation?
Oh, what's this? Huh. Hypo and hyperventilation. Hypoventilation is shallow breathing. Hyperventilation is very deep breathing.
Well, because on the slide it seems like it's
Okay, which slide are you looking at? Let me
Oh, no,
see.
I'm sorry.
No?
You did, no, I was right.
Okay. So, yeah? What was it?
Hypo and
hyper. Hypo is always less than. So those are the patients who are breathing not sufficient air exchange, and those patients who are shallow breathers would be hypo. Okay?
So hyperventilation is
Hypoventilation is the shallow, yes. Hyper, too much air, so they're taking really deep breaths, and those are the ones who are anxious and they're blowing off too much CO2, so they have tingling around their lips and their fingertips start to tingle because they're blowing off too much CO2. Make sense? So hypoventilation, too insufficient volume, hyperventilation, too much. Okay, here's that slide I just explained. High carbon dioxide is a normal stimulus to breathe for all of us who don't have COPD. Okay, so for the emphysema patient, the low oxygen concentration regulates their hypoxic drive. Hypoxia, low O2. So dropping oxygen levels stimulates them to breathe. So high flow O2 can potentially remove the stimulus to breathe. I've not seen it, but that's what we learned over the years. That is still the standard. Like I said, over the years, watch all the research is being done, and we may see that changing over a short period of time. So we always administer 3 liters or less, and you monitor for respiratory depression. If those patients do get into respiratory difficulty, we do increase CO2. Just monitor them carefully. So this is the slide that you need to just understand, normal versus COPD. Normally our O2 levels are normal, our CO2 levels are normal between 35 and 45. Those COPD patients can have CO2 levels of, 60. I've seen 70 at sort of end-stage COPD. So very, very high CO2 levels. So that's no longer a stimulus for them to breathe. Okay? I'm going to talk a little bit about artificial airways. And we already talked about this in 101L. So take a look at those. Those oropharyngeal airways. It's an oropharyngeal airway. The intent of the oropharyngeal airway is to keep the tongue from occluding the airway, from dropping back. Keeps the tongue from occluding the airway. So when you go to the OR, you will see patients that have oral airways in place. And when they start to wake up, they spontaneously spit them out. So if you have a conscious patient or who's recovering from anesthesia, you would never tape an oropharyngeal airway. Because what's it going to do? It's going to initiate that gag reflex and it'll cause them to vomit. So we don't want them to gag and retch. Never taped in. The patient automatically spits it out when they sense that it's in place. The oropharyngeal airway can be used to suction through. And sometimes you'll see it in patients who are not alert. They have an endotracheal tube in and they're biting on it. I've seen them put in an oropharyngeal airway to keep them from biting on their endotracheal tube. The oropharyngeal airway comes in various sizes for neonates to adults. The trick is you can see anatomically how that would fit into the mouth, right? You need to put it in upside down. If you're putting it in anatomically the way it looks like it should go in, as you put it in, it'll push the tongue back. So you put it in upside down when it gets to the back of the throat, you turn it so that this part keeps the tongue from dropping back to occlude the airway. So upside down to put it in. So what does this do? Keeps the tongue from occluding the airway. Okay, sometimes patients will have a nasopharyngeal airway, and it's also called a nasal trumpet. And the nasopharyngeal airway keeps the upper air passages open. If you have a patient who has one of these nasopharyngeal airways, most hospitals have a protocol that you change it from nostril to nostril every shift or every 8 hours, depending on what the protocol is, so that it doesn't put pressure on the mucous membranes and cause erosion of the tissue. The tip of the tube is just behind the uvula. So if you have the patient open their mouth and you look in the back of the throat, you should see the tip of that tube. Okay? The repositioning is important again to prevent necrosis of the tissue due to continuous pressure. You can suction through a nasopharyngeal airway. Make sure that the suction catheter diameter is smaller than the nasopharyngeal tube because you'll pull the tube out with it if it's a really tight fit. So you can suction through it. The next one is an endotracheal tube. Those mannequins in the skills lab, some of them have endotracheal tubes in place. An endotracheal tube is usually inserted by a physician or an anesthesiologist. You can have the endotracheal tube, and the endotracheal tube goes through the mouth, endo. Sometimes it goes through the nose. So then it's a nasotracheal tube. For surgery, your patients will have an endotracheal tube in place if they're getting general anesthesia. In order to insert an endotracheal tube, you need a laryngoscope with a blade on it. It has a light on it, so that whoever's putting it in can visualize the vocal cords, so they can pass it through the vocal cords and then into the trachea. It goes down to just about the bifurcation where the right and left main stem bronchus split. So it sits in the trachea. So it's just superior to the bifurcation. If it's put in too far, you won't have lung sounds, breath sounds, on the side that is not getting aerated with the endotracheal tube. Most commonly it's in the right lung because of the angle, if it is put in too far. But you just need to, as a nurse, auscultate. If you have a patient who goes into cardiac arrest and you call a code, you would auscultate while, after the physician puts it in, the physician will auscultate the chest as well. And then after you care for the patient, listen to make sure that that endotracheal tube is at a spot where it aerates both lungs, okay? So you want to make sure you ventilate right and the left lung. If you have a patient with an endotracheal tube, those patients may remain on an endotracheal tube, ideally no more than 10 days, but I've seen it go 2 weeks if they think they're going to be able to extubate and the patient can breathe on his own. If the patient's not able to be extubated, meaning the tube can be removed and they breathe on their own, the next step is a tracheostomy. But these tubes can't stay in for a long time. Also, the respiratory therapist or the nurse, if you have a patient with an endotracheal tube, you need to change the tube from side to side every shift. Haven't seen it lately, but I've seen patients who, with the tube not having been changed from side to side, it totally eroded. They had a big hole right here from that tube just continually applying pressure against the lip. So it does, continuous pressure causes pressure ulcers, right? So it can do tissue damage. You'll see them alternated. They also mark the endotracheal tube so they know how far it was in when it was first placed and that it was in a proper position. They also get chest x-rays to verify the placement of the endotracheal tube. So auscultation, chest x-ray, and then marking the tube. If you have to participate in a code and you are at the crash cart, sometimes these blades come in curved or straight. The anesthesiologist will usually find their own, or whoever's putting it in, the physician. But sometimes they'll ask you to give you a certain size blade. When you start working in acute care, look at the crash cart, see what's in it. It's somewhere there's a list and where it is, where things are located. On the endotracheal tube, if you look in the skills lab, there's a balloon here. That balloon is on the outside. If that balloon is inflated, then you know that the balloon at the tip of the tube, which sits in the trachea, that balloon is inflated. It has to be inflated to make a tight seal in order for a ventilator to work. They can't have a big air leak. What else about endotracheal tubes? Don't mess with them in the first semester. Okay, we talked about the laryngoscope. It's got a blade and a light. And then again, patients who need long-term airway support may have a tracheostomy, which is surgical incision in the neck, in the trachea, directly into the trachea, just above the larynx, and then you've seen what a tracheostomy tube looks like, right? We've suctioned through them in the skills lab. We've done tracheostomy care. Long term, some of these patients will have a speaking valve. so they can talk. It's called a passing ear valve, speaking valve. Some of your patients may have had, who had a patient that had a speaking valve? Any of you? Yours did.
And in the morning, she didn't have it. Then the RT would replace it.
In the daytime, they replaced it so she could talk.
And she couldn't eat without the speaking valve, or I don't know, and that's how she requested for a speaking valve. No, I don't know if they have to take it out or they have to place it for her
Well,
to
it has
eat.
to be deflated.
Yeah, to eat, to be safe. I like to have the cup inflated when they're eating and drinking, but
Oh, because of the cuff.
so that they don't aspirate directly into their lungs. But the speaking valve requires that the cup be deflated so that there's air passage. Air goes past the vocal cord. I don't know if that's a standard to inflate the cup to eat, but I always inflate the cup just for safety if they're eating and drinking. So if you have a patient and they have a tracheostomy and they're eating, I would suggest that you check to see if that's what they want done, just to keep your patient safe. Any questions about that? Okay, we all know about trachea, right? Most of the hospitals now have replacement inner cannulas that you just drop the sterile inner cannula in. You take the old one out, put the new one in, no tracheostomy care to be done. Some hospitals still reuse the inner cannula if that's the case. Then you have to do that tracheostomy care with the little brushes and all of that good stuff. And then suctioning. So tracheostomy care requires suctioning in most cases. So if you're suctioning, we've already learned how to do this. You connect the catheter. If they don't have an inline catheter, you connect it to suction. Remember how much suction to apply? How much suction do you apply for trach suctioning? 80 to 120. So if you go kind of in the middle at 100, you're always safe, right? Literally middle of the road. You insert the catheter without applying suction. On the way out, you apply the suction. The maximum amount of suctioning ideally is how long?
10 seconds.
10 seconds. Any longer than that, hold your own breath and see how long it is that you're suctioning. You could be suctioning out all of their residual air. Trachea may stimulate which nerve? What would you expect to happen if it's stimulated with suction? The what? How do you say heart rate increases? You do? Okay. How many say heart rate decreases? And how many just don't remember? What do you think? It decreases. So if you are suctioning and you're looking at the patient and suddenly they don't look so good, or if they actually have monitoring going on and you see the heart rate dropping precipitously, stop suctioning. Apply the O2 again. So don't keep suctioning. Don't just pay attention to the procedure. Pay attention to your patient while you're doing it. So watch the patient, watch the monitor if there's a monitor, and look at how the patient is doing with the suctioning. As far as suctioning is concerned, before you start suctioning, what do you need to do? Provide, yeah, we hyperoxygenate, yeah. If they're on a ventilator, most nurses will just hyperoxygenate on the vent if they're going to suction. If they're not on a ventilator, how do we do that? That ambu bag, hook O2 up to the ambu bag, hyperoxygenate them, and then you suction, okay? And then oxygenate them in between passes, especially if they're really fragile in terms of their respiratory status. Give them a chance to kind of recover so you don't make one pass of suctioning, rinse out your catheter, and then pass it again. So give them some O2 in between, hyperoxygenate them, and then suction again. So watch your patient. Most patients who recover from having had a tracheostomy in place will say that suctioning was painful. So it's not something that is without discomfort for the patient. Occasionally we'll have patients who know when they need suctioning, and they'll ask you, they'll indicate they need suctioning, and they'll be relieved that they can breathe better. But it's not something that anyone enjoys having done. So assess your patient carefully, suction them when needed. So how do you determine if they need suctioning? Auscultate their lungs. And if you hear, okay, gurgles, rhonchi, where are those?
Left and right,
In the large airways, right, not in the alveoli, then you would suction them. Suction the patient, reassess the chest, the lung sounds, auscultate again. If it sounds like it cleared up, you did a good job. If there's still, and sometimes you see copious amounts of secretions pouring out of that tracheostomy tube. You, in many cases, then need to suction them more than once. I have an article here from the American Journal of Critical Care from March of 2010, and it's called Current Practice in Airway Management and Descriptive Evaluation. They looked at how respiratory therapists and nurses dealt with patients who were on ventilators. I just wanted to share with you something that you will see in hospitals. When the respiratory therapists suction patients, they very often inject some saline. Those little pink things full of saline. I think it's 10 milliliters of saline. The research in the last 20 years has clearly indicated that it is not a recommended procedure. So if you're working with a respiratory therapist and they do that, just make sure that you don't do that as well. All of the research has shown that that is not a recommendation because, I'll read from here. It says the respiratory therapist instilled saline frequently and RNs rarely did. These authors recommend that instilling saline before suctioning should be discontinued, but that's been a recommendation for 20 years. So at least for all the years I've been teaching, we've always said do not instill saline. And the research has shown that installation of saline has an adverse effect on oxygen saturation. And another risk is the occurrence of bacterial biofilm on the endotracheal tube, as well as injecting that saline may dislodge bacteria from the wall of the endotracheal tube into the airway, and it may increase the risk for ventilator-associated pneumonias. So if you see it done, do not do it. Okay, there are certain procedures sometimes where it's necessary, but routine suctioning does not include instilling saline. So even though it's at the bedside, it's not helpful for the patient. They've also shown that if you put that thick, tenacious mucus in a test tube, and then you add some saline and you shake it vigorously, it'll never mix like oil and water. And it just sort of sits at the carina, forces in potential bacteria causing pneumonia, so it's not something that we allow the students, or we recommend that the nurses not do that. Okay, some more details on suctioning. It's supposed to be set, the pressure should be set between, this one says 100 and 120, the book says 80 to 120, so go with about 100 and you're safe. You determine when suctioning is needed by auscultating the patient's chest and listening for respiratory sounds that indicate that there is fluid in the large airways. If the patient can cough, that's always preferred to being suctioned. So if the patient can cough and generate a vigorous cough, often they're not strong enough to do that. That's why we do suction them. But some patients can generate a tremendous forceful cough. So if they can cough it out, that's good. If they need assistance by suctioning, then that's what we would have to do for patients who can't generate a really strong cough. It's a sterile procedure, so you only use the catheter once. If you're using that sterile catheter, you use it to suction the tracheostomy or endotracheal tube first. You can then use that same catheter to suction the oropharyngeal airway, or above the tracheostomy tube and the oral cavity. You may never go back then because the oral cavity is not sterile. You can't go back to the airway then. But you can use that same catheter to suction orally. If the patient has, in fact, if they have, sometimes they have thrush or some sort of organism that's in their oral cavity, you may want to use a different catheter, so that just a regular suction catheter, you wouldn't use it for the lungs anyway. But if you have like a lung infection, don't move those bacteria or that organism to the mouth. So just be aware if the patient has any sort of infection going on. Okay. Just to summarize, it's a sterile procedure, suctioning. You need to find the sterile catheter, sterile glove. How many hands can you contaminate? One. Okay. Limit suction to 10 to 15 seconds, and that includes the time you put the catheter in, from the time you start. That's not just from the time you apply the suction. I would not recommend 15 seconds. That's an awful long time if the patient's not breathing. So limit it to max of 10 seconds. Auscultate the lungs to evaluate the effectiveness, and you may have to make a second pass in between. Hyperoxygenate the patient again. Okay. Some patients will require a chest tube, and you'll learn about chest tubes in the 3rd semester. So all we're trying to teach in the 1st semester is how you need to keep the patient safe. So you're not learning, we don't necessarily expect you to set up a chest drainage, the whole setup and the tubing and all of that, but we want you to recognize, you'll see patients in med-surg who have chest tubes. I have a couple of stories to tell you that where things didn't go so well. I had a student who had a patient with a chest tube, and the chest tube is the chest drainage container is located on the floor. So the patient's beds are required to be in the lowest position possible when you're not in the room. So not paying attention to where that was on the opposite side of the bed, the student lowered the bed, and this big crash, and blood and liquid all over from that chest drainage container, and just shattered the collection container. I had another student who had to get a patient out of bed. They have lots of tubing that goes so they can sort of maneuver out of the bed and into the chair. It's usually yellow rubber tubing. My student was going to get the patient up and move the patient to the chair. The patient didn't need a tremendous amount of assistance, but she was going to help. Didn't pay attention to where and what was on the floor. Kindly stood on the tubing, and then had the patient on 3. We're going to stand up, 1, 2, 3, and yank the chest tube out of the chest. Those chest tubes are sutured in, okay? So just pull the doggone thing out. In both situations, you know, you're going to have your nursing instructor's going to have heart failure to do that kind of stuff. So pay attention. Pay attention whenever you move a bed. What's it hitting at the top? Is that IV pole going to hit the light? Is that the frame that's on there for orthopedic patients? Is that going to hit something? I've had lights, beds going up and puncturing through lights. And I'm sure staff has done it too, but we're trying to teach you in this semester, if you have a patient with a chest tube, how to keep the patient safe. So the purpose of the chest tube is to remove air and fluid from the pleural space. When you have a lung collapse, the negative pressure that's normally in your lungs is lost. So we're trying to re-establish that negative pressure. That negative pressure what keeps your lungs expanded. So once that negative pressure is lost with a stab wound, gunshot wound, sometimes spontaneous collapse of a lung, they need to put in a chest tube to re-establish that negative pressure in order for that lung to re-expand. So if you have a patient who has a chest tube, they may have more than one. If they have upper chest tubes, it's usually to remove air, if they've had a pneumothorax. If they have both upper and lower, the lower ones are usually to remove blood or fluid from the lungs. You can just sort of watch what's coming into that drainage container. And you can see one of those drainage containers right here. This one, a Pleurovac. And you can see there is chest drainage will collect in these and you just measure how much is coming in. So each shift, one of the things you have to do is measure the output. You have to do intake and output on every patient all the time, whoever you care for, even if it's not ordered. We expect you to maintain intake and output on your patient. So for the output, we do not want you to disconnect anything, okay? Normally, you empty the Foley bag, you empty the surgical drains, you empty the NG drainage if need be, or change the container. We do not disconnect and empty chest drainage, because once you disconnect it, there's the risk of the whole lung collapsing again. You lose the negative pressure. So what we want you to do is look at the chest drainage container when you come on the day shift, or whatever shift you're working. In the future, you may work night shift. When you come in, watch, take a look at where the night shift made a line, and they'll date it and the time. So if the night shift made a line at the 300 here, and at the end of your shift, it is at, I think that's 400. I think so. That's 400, doesn't matter. Then if this is 3 and now it's up to 4, you're going to document the output of 100 milliliters. Okay? So you have to document intake and output. And you need to get a sense of what to do if you have one of those unfortunate things happening to your patient. The chest tube gets pulled out, or the chest drainage container breaks or becomes disconnected. So if you have a patient who has a chest tube, we want you to, and it becomes disconnected, if the tubing becomes disconnected and you can't reconnect it right away, get a bottle of normal saline, sterile normal saline. Put the end of that tube into the sterile normal saline, and then you have water seal. The lung will be able to re-expand, and then you can have the nurse go and get a new Pleurovac and hook it up, okay? If the chest tube accidentally gets pulled out, what are you going to do? Yeah, some books say pinch the hole where the chest tube was, pull the skin together, and then put an occlusive dressing over it. Often we use what's it called, Vaseline gauze. To put it over and then put some 4x4s over that, call the physician, and they'll have to reinsert the chest tube. Sometimes it was at the end and the patient's doing okay, but generally that chest tube has to be reinserted. So to keep them safe, watch where all the tubing is. Make sure the patient's not laying on any of that tubing. That rubber tubing is pretty soft, like I said, it's long. Make sure there's no kinks in it anywhere, because it needs to be patent in order for that whole chest drainage and the chest suction to work effectively. Often it's to suction, sometimes it's not to suction. All depends on the patient's status and the patient's needs, okay? But watch where you're stepping, watch where the patient's stepping. If you do take the patient, and many of them, we take them for a walk, they need to ambulate and maintain some level of activity. In most cases, we want them to get moving. Then if you're taking the patient on a walk, that chest drainage container may never be raised above the level of the lungs, okay? So it needs to stay below the level of the lungs. The patient's laying down in bed, needless to say, it's below the level of the chest because it's standing on the floor. So you don't want to hang it on an IV pole where it's at chest level. You want to hang it, if you're walking with an IV pole, at the bottom, so that there is continuous opportunity for chest drainage to drain into the collection container. Sometimes patients become confused and they pull out their chest tube. But when it was student-related, in both cases, the physician was not a happy camper. And the patient was not a happy camper. So pay attention. You can see here that it's sutured in. It has pretty thick sutures. So a lot of force to pull those sutures out of the skin. Okay? So a chest tube is used to remove fluid and or air and or fluid from the pleural space. So if you have a pneumothorax, it means there is a collapse of a partial part of the lung, or it could be an entire lung. Could be just a lobe, could be an entire lung. If they have a hemothorax, there's been usually chest trauma, there's bleeding, so you'll see blood draining into that chest drainage container. If they have a pneumohemothorax, they have a combination of the two. The lung has collapsed, and there may have been trauma as well, gunshot wounds, stabbing, motor vehicle accident, some sort of chest trauma that caused bleeding as well. So that would be a pneumohemothorax. Okay, we used to have clamps at the bedside. I haven't seen them for a long time. For chest tubes, can you shed some light on that? Still use clamps? They do.
They use the scissor ones now, like the
Oh, yeah. Haven't seen them at the bedside on the med-surg units at Kaiser at all. So we used to have the clamps available, but then if the patient had a tension pneumothorax originally, I think the thinking was that if you then clamp it, it might then cause a tension pneumothorax again. So I haven't seen clamps, but we used to have them at the bedside all the time. So some hospitals may still have them. You may not see them at all. The sterile occlusive dressing, pinch the skin together, put the sterile occlusive dressing, usually a Vaseline dressing, over the hole where the chest tube was pulled out, or if the chest tube was discontinued, was pulled out because the patient's lungs had re-expanded, you would do the same thing. If the unit becomes disconnected, you don't know how to fix it, a bottle of sterile water, put the end of that tubing that comes from the chest tube. There's lots of tubing I mentioned attached to that, very securely taped. The end of that tubing would go into a sterile bottle of water until the nurse could bring a new collection container, pneumothorax, a Fluorovac, or whatever brand they have. You need to know these sort of emergency things, what to do with that chest tube.
I have a question.
Yes.
If the tube comes out, do you use the sterile water thing for any kind, either one of those three regions?
The sterile water is to put the tube in because you need water seal.
For all those, the pneumothorax, hemothorax, for all those, do you use a water seal?
All of them are, yeah, that container, that's the picture I had, that's to water seal. There's water in one of the chambers, and basically what you want to happen is you want if there's an air leak, you'll see bubbling in that water chamber. But air doesn't go through water. So that's why they call it a water seal. If the patient has an air leak, you will see about bubbling, but you can't breathe in or suck in atmospheric air through water. Does that make sense? I'm not sure if that makes sense. That's why it's in a water seal. So if the chest tube becomes disconnected, in some places you may see clamps at the bedside. You would just clamp that chest tube so that the atmospheric air in the patient's room doesn't flow into the chest and collapse the lung. Okay? When the chest tube is removed, you'll put that sterile occlusive dressing over it with some 4x4 gauze, and then they'll tape it really securely to make sure that there's no air leak in there. Yeah. A tension pneumothorax is like a one-way valve. Atmospheric air, when the patient breathes, can go in, but it can't escape out. So what happens is it shifts the contents in the chest, the lung and the heart, the aorta, the trachea. It shifts it in the direction to the good side. To the good side, yes. I'm glad I have a respiratory therapist here. It shifts, because it's a one-way valve, air going in and out, only air goes in and then it sort of seals over. And
That's
so,
a balloon with a flap, and you just keep putting air in, and the balloon keeps getting bigger, and the organs in the body are going to just shift over with the trachea and everything.
yeah, the aorta, large blood vessel coming off the heart, everything shifts over. So that's tension pneumothorax. If that was the reason for the original insertion of the chest tube, then the thinking used to be with a clamp that if you then were to clamp it, then in the meantime that patient could again develop a tension pneumothorax, shifting the contents in the chest to the good side, because the one side keeps getting air and air and air, but it can't escape.
Is there one where it's like one of the vessels in the heart, right, like ruptured or something, and they're bleeding, and it moves it from the blood and the...
Like an aortic aneurysm?
Yeah. Is there a special name for it? I can't remember. I just thinking about
Aortic aneurysm, a ruptured aneurysm, a leaking aneurysm. But we don't use chest tubes for that.
Yeah.
It is an emergency. They need immediate surgery before they die from blood loss.
Yeah.
But generally, no, that's not related. That's not the cause of the lung collapse. That's a separate issue. Yeah. Okay. So how are you going to keep your patients safe? Make sure there is no kinking in the tubing. Make sure that when the patient gets up, they don't stand on it. You don't put the chair on it. You don't step on it. There are no kinks in the tubing at all, okay? So that there's opportunity for chest drainage to go into that collection container. What else? Those of you who read the book, does it say anything about milking the chest tube?
I didn't see that.
No, okay. I don't think we do that anymore because research has shown that it causes too much negative pressure in the chest. Okay.
The same as like stripping them?
Yeah. You don't do that anymore. You used to.
I've seen them do them on the heart patients, so. I mean, I'm not supposed to, but.
Not supposed to anymore. We used to, that was a standard thing. We would milk, they call it milking the chest tube, stripping the chest tube, same thing. Trying to make sure that all those clots would drain into the collection container. But they found that it causes more damage to the patient's lungs than it does benefit them. So you shouldn't be seeing stripping or milking of the chest tubes anymore. But it was the standard. So some people keep doing what they learned originally and they don't keep up with new practices, so you may still see some of that. And it may still be indicated with large clots, but routinely we don't do it anymore. We used to routinely do that, I think, every hour, but not anymore. Okay, so non-surgical management of patients who have lung problems, that incentive spirometer. I didn't bring one, but there was a picture of one, I think, in one of those slides. Wasn't there?
Yeah.
There it is. Oh, next slide. Okay. So incentive spirometer is a little gadget that has a small piece of tubing with a mouthpiece on it. Okay? Almost all post-op patients get an incentive spirometer. So you will be teaching patients how to use an incentive spirometer. The purpose of the incentive spirometer is to encourage deep breathing, to allow those lungs to re-expand post-op, and to prevent post-op pneumonia. It's a handy gadget to have because the patient gets visual feedback as to how well they're doing their deep breathing exercises. The intent is to continually move that little lever up, this one, start maybe at the level where they're taking the deepest breath and then move it up maybe the next shift, the next day, so that they continually have a challenge to take deeper breaths. The intent is for them to take a really slow, deep breath. We don't want them to breathe fast. So we want them to do it really slowly, and in order to give them that visual feedback, this little thing goes up and down when they take a deep breath, and you'll see these little arrows, and it says keep this little thing right between those arrows. And if you breathe, take a deep breath way too fast, that thing just shoots up to the top and it's not effective. So we want them to take slow, deep breaths. We want them to hold the incentive spirometer upright, like this gentleman is doing. Hold it upright. And then take a really slow, deep breath. Suck in on this mouthpiece. I have seen patients who are using that incentive spirometer, and you look at them, and what are they doing? They're blowing into the mouthpiece. Like, why are you doing that? Well, that's how the nurse taught me. The intent is for them to inhale slowly, to suck in the air, to fully expand their lungs. So they have to put the lips around the mouthpiece and then create a really tight seal and take a deep breath, and then visually watch to see how much volume they can inhale, as well as making sure that they go slow enough to keep that other little monitoring device on the side in the center. So they have to keep that, usually we ask them to keep that raised to the top level about 3 to 5 seconds. So nice deep breath, and then remove the mouthpiece and exhale slowly. You can ask them to use pursed lip breathing if you'd like, but the intent is to inhale on the mouthpiece, not to blow into the mouthpiece. So when you're doing the teaching, make sure that you teach them to inhale slowly and also exhale slowly, okay? And you'll see an order for most of these patients says IS, Q1 hour while awake. So IS, Q1 hour WA. Incentive spirometer every hour while awake. It's your job as a nurse to say, see this little incentive spirometer? Show me how well you're using this. And then watch them take, how many breaths should they take? 10 usually is a standard, 5 to 15 depending on how well the patient's able to do this. So incentive spirometer every hour while awake, or sometimes we say, you're watching TV, every time you see a commercial, take a breath on this thing. And nowadays, of course, the commercials last for minutes long. But that way, at least, they're continually doing it every few minutes, taking 1 or 2 deep breaths. So the intent is every hour, 10 to 15 times every hour. Okay, sometimes patients need some sort of respiratory, it's called percussion, vibration, and postural drainage, also called chest physiotherapy, generally done by the respiratory therapist. I can remember having to do that on my adult patients because I am so old, there were no respiratory therapists when I graduated from nursing school. So we did all this stuff. Nice to have respiratory therapists taking over a lot of those things that used to take a long time. And the intent is to mobilize pulmonary secretions to get them into the large airway so they can cough them up. So you evaluate your effectiveness of percussion, vibration, and postural drainage by how much fluid secretions you're able to suction out or they're able to cough up. They also used to call it cupping and clapping. So that's why on the bottom one, the hands are cupped, and then the clapping as well. So you're trying to isolate a particular lobe of the lung that is sort of consolidated with secretions, and then providing that vibration, cupping and clapping, trying to get those secretions to mobilize, get them into the large airway so they can cough it out. Any other questions on that? I think that's sort of all I have on postural drainage. So the percussion is also called the clapping. You see on the bottom? The cupping and percussion is the clapping. The vibration is where they do, the hands are on the chest and they start kind of quivering to loosen those secretions. The hands are placed flat against the chest versus the cupping where they're not flat against the chest. Respiratory will do this for you. And usually it's done during exhalation so that it promotes drainage of secretions. What else? Okay, sometimes these patients who have respiratory problems have surgery. And a pneumonectomy is a removal of, ectomy meaning removal of, pneumo meaning lung, removal of an entire lung, okay, pneumonectomy. So those patients, generally, if they've had a pneumonectomy and they just came back from surgery, the first couple of days after surgery, you do not turn them on the operative side. So turn them only to the non-operative side. Turning them to the surgical side where the lung was removed puts too much stress on the bronchial stump. So do not position them on the operative side. Okay? It may disrupt the suture line. If you have a patient who's had a pneumonectomy, it could have been for lung cancer, any kind of like unilateral TB, they've done pneumonectomies. If the patients come back from surgery, do you think they have a chest tube in place?
No. No, there's no lung there.
There's no lung there. Good critical thinking. There is no lung there to re-expand, so they will not have a chest tube. Okay? Sometimes a lobectomy is done. Like if they have lung cancer and just a single lobe, they may just do a lobectomy, removal of a single lobe of a lung. When those patients come back from surgery, do they have a chest tube? Yes, because they want to re-expand the lung. Often thoracoscopic surgery is done where they use a scope, insert through a very small incision in the chest wall to remove tumors, to get samples of malignant or non-malignant tumors for diagnosis. And some patients who are not a surgical candidate still do that thoracoscopic surgery on patients who are poor risk for having actual surgery. What else? So for a lung biopsy, they may use a scope. What else would they use that for? Lung biopsy, tumor biopsy, whatever. Okay. Sometimes they use the scope to drain, like a lot of purulent drainage from the lung if they have empyema. Empyema is a lot of purulent drainage. What's another word for purulent drainage? Does anybody ever read the book? I just want to give you a heads up, because you guys are all just not participating. I want to give you a heads up. When you get to clinical and you have any kind of patient we've lectured on, or even if you haven't lectured on it, you'd better know what to do. So whatever you learn here, you can't consider this a little section of a course, 101 here, 101L over here. Everything you learn here, the purpose of clinical is to apply what you learn in here to the patients you have in clinical. So you can't forget how to suction when you get there. You can't forget how to position a patient who's had a pneumonectomy. You can't, forget how to, how to assess for bowel obstruction. Okay, you learn how to do that. Now in clinical, when your patient, or you suspect a patient, you need to know what to listen for, where to find it, and what it means. So all of your blank stares is fine with me, but keep in mind your clinical performance is based on how well you apply what you learn in here. They're not two separate courses. And if you're not reading the book, I suggest you start. You can't pass this course. Everyone who has failed this course, when I asked the question, did you read the assigned readings, the answer was no. I was told that the just reviewing the lecture notes was sufficient. Okay? So I'm not trying to intimidate you, but really get with it. This is building. Next semester, this is prior learning. So if you're in clinical and you have something you learned in the first semester, they'll write you up for not having, being able to apply prior learning. This is a simple to complex. So every semester, they're going to add on to what you've learned here in the basics, and then you get more and more detail into type of complicated patient that you would see like at the end in the fourth semester. So everything you learned in the first couple of modules, and as we progress, you can't, I've had students who come to clinical and they have a patient, they've already had the GI lecture, and they're clueless about what to do with this patient. Well, did you have the GI lecture? Yes. What do you remember? Nothing. So don't just study for the test. Study it from the perspective of, oh my gosh, if I have a patient who has this, I had better know how to care for them. And understand, if you don't understand the whys, the rationale, you are lost. So always know why you're doing something. You don't place that post-op patient who's had a pneumonectomy on the operative side because that puts too much pressure on the surgical site, on the stump that's left where the lung used to be attached. But if you can't verbalize the reason why you're doing things, then you're just doing things by rote, and you can teach anyone else to do those sort of things and without an explanation. You're the one who gets paid for your critical thinking, okay? So understand what you're learning and apply it to your patients, because patients will die. They die every day from people who make stupid mistakes. We're all going to make mistakes, but you don't want to make mistakes that cause someone's demise. Yeah? Okay. So learn it from the perspective of not just stuff for a test, but attach your patient to it. When you're in clinical, we're in clinical on Mondays and Tuesdays. When you're in clinical on Monday night, every one of you should go home and look up that medical diagnosis, look up the plan of care, come back the next day and say, aha, I didn't know that I needed to monitor these labs and these meds are appropriate and the interventions that need to be provided for those patients. If you don't do that, you're as lost the second day as you were the first. By 10 o'clock every morning, after you've done your head-to-toe assessment, you should have a nursing diagnosis. If you don't, and you go home without having a nursing diagnosis and having implemented the plan, you have wasted your time. And your patient, more than likely, didn't get appropriate care. So your priority nursing diagnosis is related to the priority medical diagnosis that brought them there. Your nursing diagnosis, if you make connecting lines, is directly connected because one of the signs and symptoms has been assessed by you for that patient, and that's your priority. You had better have 6 things you're going to do that very first day for that patient's primary problem. Okay? Sounds scary? I know. If you don't know what the nursing diagnosis is by 10 o'clock, and your instructor hasn't come around, you approach your instructor and say, I don't know what the priority is. So the question will be, what deficit did you find? Why is the patient here? So you should always know why the patient's here at the hospital. I've had patients at the end of the day say, why is your patient here? Because, we don't always get around to all 12 first thing in the morning. Well, I don't know. Looks like the patient had surgery. What kind of surgery did he have? Oh, I don't know. Or, so associated with this, you have a document in your nursing student guidebook, and it's called, what's it called? Unsafe Clinical Practice? Does that ring a bell? Read that document. If you don't provide appropriate interventions, if you don't do things on time, if you don't know why your patient's there, those are all considered unsafe clinical practice. So now that I've been on a tangent, read your book so you can answer questions. And if you don't understand something here in lecture, ask the questions so that we can clarify it here. Because it's not just to learn things. You're going to learn to keep your patient safe. Thoracentesis, aspiration of fluid or air from the pleural space. What kind of patients do you often see who need a thoracentesis? Thoracentesis. Sometimes trauma, but often it seems to be, at least my experience has been, they're terminally ill cancer patients, and that pleural space keeps filling up, and usually that's pretty much towards the end when they can't, they'll come in because they can't hardly breathe. They'll have tremendous relief when all that fluid is tapped and drained from their chest, but it keeps coming back. So for the most part, mostly malignancies that they're in the hospital for.
For the pneumonostomy, so when the entire lung is removed, how do they function?
How do you function with one kidney? You have 2 kidneys, you can live with one, right? You have 2 lungs, you can live with one.
So as long as they still have
Yeah, so you can have half of your liver removed and still live with the other half. Because sometimes they'll take a lobe of a liver and transplant it to a patient who needs a lobe. Yeah.
or
So
will their function be the same as with?
They adapt pretty well. You want to just make sure that they don't develop pneumonia or respiratory problems, just contract anything that, like pneumonia or anything that would cause them to have respiratory problems, because they don't have any reserves. They only have that one lung at that point. So one of the things you have to remember on patients who have had a pneumonectomy is positioning post-op. And then usually the discharge teaching is for the first 2 weeks or so, we usually teach them to take their temps every day. Why do we do that? Because if you have an infection, what happens? Your temp goes up. So we usually encourage them to do that and to call the physician if there's any issues at all, to come in immediately instead of waiting to see what happens. Pneumonectomy, I have another couple of little stories to tell. A couple of times we've had a patient who's had a pneumonectomy, but that's not why they were there. They had some other reason for admission. So on assessment, I was doing the head-to-toe assessment with one of my students, and we were listening, and I said, I can't hear anything. Can you hear anything? And the student said, I heard breath sounds this morning, and I said, okay, well, move the stethoscope. Let's just check all the areas. I don't hear anything. And the patient started to laugh, and he said, ha, you're the first one who has noticed that I don't have lung sounds on that side because I had a lung removed. We looked at the patient's medical record, and all of the nurses had charted normal lung sounds bilaterally. So what did that tell you? Did they really listen? No. But everybody, he said, oh, nobody else picked up on that. But my student had also heard lung sounds in the morning until we did the head-to-toe assessment. I said, I can't hear a thing. So I had the patient take another deep breath, and I said, there are no lung sounds. And then I saw this huge scar, and I said, did you have lung surgery? And he said, you're the first one who picked up on that, and I have no lung on that side. And so don't chart anything that you don't hear. What's that considered? Not, well, falsifying, but what does that tell me about the nurse? Not very competent. You're not very thorough, right? You can't assess the absence of breath sounds. What if it was absence of bowel sounds, and you're thinking you hear them in all 4 quadrants? And in fact, the patient now has paralytic ileus, and the bowel is not functional. We can't just make assumptions that the patient has breath sounds on both sides. So sometimes if you don't hear anything and you see a scar, now with a lot of the surgeries using the scopes, you may not see the big incisions like we used to see for pneumonectomies, but ask the patient. If you don't hear something, verify that and document it. Okay. Sometimes we give patients, respiratory gives patients medications through a nebulizer. So if you see that on the MAR, respiratory therapy will come in and usually administer the medications by nebulizer. Okay? If you have a patient who has inhalers, nursing will administer the inhalers. Okay? And nebulization is the process of adding moisture. It's something that has a little container here that has meds in it, and it allows the patient to inhale that medication by mixing with some air, and it's more effective that way. It'll kind of make a hissing sound, and when that little chamber with the drug in it is empty, it stops hissing. Okay? So if you're monitoring the patient, respiratory will come back, and often they'll even tell the patient, when this is all gone, you can just put it aside, and I'll come back. They don't always stand at the bedside while the patient is getting that respiratory treatment. Okay, a little bit about medications. These are all the different categories of medications that you might administer. You probably remember all of these from PhRMM, or if you're currently in PhRMM, you'll learn about them. Those beta-adrenergic agonists are bronchodilators. So I don't ask you the names of them. You just need to know that bronchodilators are also called beta-adrenergic agonists. If you have patients who have more than one inhaler, then you need to wait at least a minute or so between inhalers, so they shouldn't do one puff and then pick up the next one. So give them some time for that to get into their lungs, and then give them the next inhaler. The xanthines, usually you have to teach the patient not to crush or chew. They're mostly sustained release doses. If you're giving the aminophylline per IV, it may cause tachycardia, and the patient may complain of that. Those anticholinergics may cause headaches, very dry mouth, and sometimes nervousness for the patient. The corticosteroids, very commonly used, inhaled corticosteroids. Those corticosteroids, the inhaled corticosteroids, do not have the same effect as the corticosteroids that are taken orally. And if you have patients who take corticosteroids orally, that has some significant side effects. What are they? Thrush. Oh, back to thrush. On those inhalers, read your drug book. An awful lot of them that are steroid-based, it says, have the patient rinse their mouth after they use the inhaler. And again, lots and lots of patients will say, you're the first one that has me do this. I do it at home, but nobody has ever mentioned that I need to rinse out my mouth after using the inhaler. So read the book. If that's what it says for instructions, then make sure that you offer that to the patient. Those corticosteroids can cause, if it's oral corticosteroids, often cause over time, severe osteoporosis. Keep that one in mind. What else do steroids do? You can get a moon face, really long-term, like your transplant patients will have that rounded moon face from steroids. The what syndrome?
Potato man syndrome.
Potato man syndrome.
I mean, that's
Oh, I mean the moon face?
You look like a potato man.
Oh, okay, yeah.
Mr. Potato,
Yeah.
So you're round with like thin arms.
Okay. I've also heard them call that the Michelin Man.
Michelin Man.
Potato man. Okay. All right. So on those corticosteroids, if the inhaled medication is steroid-based, you must have the patient rinse their mouth out. So don't forget to do that. And what's the purpose of that? Prevent thrush or candidiasis. What does thrush look like? Kind of white, patchy layer on your tongue. Okay. What else do corticosteroids do if they're not inhaled, but they're oral? The what?
Increases your heart rate.
Not so much increasing the heart rate. What does it increase?
Blood
Blood sugar. So if you have a patient with high blood glucose levels, if you look at their labs, and you know they're not diabetic, look and see if they're taking steroids. Often because they're taking steroids. What else do those steroids do? They increase your blood sugar.
Lower your immune system.
They alter your immune system to the positive or negative. Negative. It inhibits your immune system. Why does it inhibit your immune system?
Because it suppresses your immune system.
How? Think. Oh. Why does it decrease the immune system? What do you need to have an intact immune system? What kind of cells? White cells. Where do they come from? The bone marrow. So steroids depress the bone marrow and therefore decrease the production of white blood cells. Okay? Because it inhibits the production of those cells in the bone marrow. What else about corticosteroids? I think the major thing is the blood sugar, blood glucose, high risk for osteoporosis, the immune system is diminished, and what else? I'm sorry? Yes, osteoporosis, significant, very significant, and it happens, gosh, I've seen patients in their 40s who've been on oral steroids because they have chronic respiratory disease, who have spontaneous fractures because they have some terrible osteoporosis. So it's not a good drug for a lot of reasons, but a great drug for many other reasons. So everything has side effects. Sometimes we give expectorants to make the cough more productive. The mucolytic, not recommended for many patients. It's not recommended for patients who are intubated, but we will see mucolytics being administered. Decongestants, yeah, we don't give a lot of those, I don't think, in the hospital to patients. If you do give decongestants, they recommend it to be given at bedtime because they cause drowsiness. So don't memorize all these meds. Remember the highlights. Which one? Corticosteroids and okay, and which ones do you have to rinse the mouth out? Steroid-based inhalers. That's all you need to know. Okay. So, evaluation of goals and outcomes for oxygenation, maintain a patent airway, improve comfort and ease of breathing. How can you improve comfort and ease of breathing? Set them up in high Fowlers, maybe the tripod position, turn on a fan. What else? Anything else? Incentive spirometer, very, very helpful in re-inflating those lungs, helping them to feel better. If they're better oxygenated and all the tissues are better oxygenated, their muscles are getting adequate oxygen, you can get them out of bed and ambulate them much better than if they're poorly oxygenated. And of course, we try to, at all times, get those patients moving. Do not allow your patients to stay in bed if they're not ordered on bed rest. They lose a tremendous amount of strength, and the more you ambulate them, move them around, the better it is for them, and the earlier they can be discharged. One of the outcomes here is avoid risks associated with oxygenation problems. What are some of the risks we talked about?
COPD.
Okay, the COPD, no more than 2 to 3 liters. If you have oxygen toxicity, the signs and symptoms are often similar to for an MI. They'll have chest pain, dyspnea, but usually we manage, the respiratory really manages those patients well enough that generally we don't see oxygen toxicity, but it can occur. Okay. Any other questions? Oh, I have some sample questions. Want to see some sample questions? And I didn't put them on with, I didn't bring the clicker thing.
We didn't either.
You didn't either?
Oh.
Okay, sample question. I'll try to remember to do that each time. How many say A? How many want B? C? D. Well, everybody didn't raise their hand. You're still reading. Okay, keep reading. Okay, the polling is closed. Who wants A? Who wants B? C? D. Wow. Yay! A is the correct answer. A sterile procedure, you have to use a sterile catheter each time. What can be reused and maybe replaced every 8 or 12 hours? The Young Power Suction Wand. It's a very rigid wand, about yay big, and it's for oral or oropharyngeal suctioning. You will see that placed back into the little paper wrapper and at the bedside, and it gets replaced usually every shift. You can't protect it in your sterile packaging because once it's out of the package and has been used, it's no longer sterile. And you don't disinfect anything with peroxide, certainly not going into the airway, because peroxide is cytotoxic and causes damage to the lung tissue. Okay. Too tired to eat, those are the patients who look so cachectic, so thin and so frail, because they have such an effort breathing. All of their energy goes into getting sufficient air into their lungs. So what's the problem? What's the nursing diagnosis? Okay, the problem is weight loss, too tired to eat. So it has to be something related to nutrition. Yes? Okay, so it's altered nutrition, less than body requirements related to fatigue, as evidenced by what? What else? Yeah, what else? Steady weight loss. What else? If they're getting a meal tray, well, what would you assess? Ate less than maybe 50%. Okay? Activity intolerance related to dyspnea. Okay, as evidenced by, if you have activity intolerance, do you remember what has to be evidenced by minimum? What does that mean if you have activity intolerance? Yeah, so a lot of patients, end-stage heart disease, COPD, they have no reserve at all for any activity, because activity uses oxygen, and the oxygen supply does not meet the demand that's required when you move, and the muscles need O2. So it's a activity intolerance related to imbalance between oxygen supply and demand, and then that should be, as evidenced by dyspnea, unable to walk more than 5 feet, and with activity, heart rate and respiratory rate increase. That would be as good as evidenced by. Weight loss related to COPD, not a nursing diagnosis. Okay? And you can't have a related to, that's a medical diagnosis. You can say secondary to, but you can't use a medical diagnosis for a related to. Ineffective breathing pattern related to alveolar hypoventilation, related to. The cause is alveolar hypoventilation, right? As evidenced by, what would you see? Patient may be cyanotic. Yeah. Maybe short of breath. If you have a patient in an ineffective breathing pattern, you better fix the ineffective breathing pattern relatively quickly. So a lot of those patients, if you're looking at a nursing diagnosis, will end up on a ventilator. Because if it's ineffective and you can't breathe well enough to sustain your life, some intervention needs to be provided that will allow them to have an effective breathing pattern. Okay. The PaO2, what does that mean? What does that stand for? Partial pressure arterial O2. So how do you get the PaO2? That's SpO2. ABG, yes. So which statement is true concerning oxygen administration to a patient with COPD? Okay, which one? B, because normally hypercapnia is what stimulates us to breathe, right? But those patients always have hypercapnia. Remember that word? Okay. But those patients with COPD have a hypoxic stimulus to breathe, low O2 levels. The O2 level needs to drop to be their stimulus to breathe. Yes?
Yes.
There you go. Next. How many want A? B? So you're right in many. It's not the right answer here, but why would you turn the patient every 4 hours if the patient has a respiratory problem, not respiratory distress? Because especially if they have bilateral pneumonia, you want to turn them very, very frequently because the lung down gets the best perfusion by gravity, the blood flow. The lung up gets the best ventilation. Then you flip them over to the other side. Now this lung gets the best perfusion and the lung up gets the best ventilation. Very important to turn those patients very, very frequently to get the benefit of the best perfusion and the best ventilation. So yes, that turning is critical. What else? Administering sedatives to promote rest. The patient who has acute respiratory distress is anxious. You need to provide some intervention besides putting them to sleep, right? So what's the best thing to give them to address their respiratory distress? The morphine, because it does what? Relieves both dyspnea and the anxiety. Not the pain, the dyspnea and the anxiety, but it's a good pain drug too. Suctioning if the cough is ineffective is what you would do if that airway clearance. The key here is airway clearance. How do we keep the airway clear? What nursing interventions would be best to promote good airway clearance with good ability to cough up those secretions? What are those nursing interventions to prevent those secretions from getting so thick and tenacious? So what? Fluids, how much? 2 to 3 liters a day. So if you get the patient, keep the patients well hydrated, it prevents those secretions from getting so thick and tenacious that they can't clear their airway. What else? Walking, but intervention for the secretion. Fluids, unless it's contraindicated. Remember that example I gave of the patient, of the student who gave that patient tons of fluid and also had underlying CHF? The person went into pulmonary edema. What kind of secretions do they cough up? Frothy pink. Don't forget that one. You put the patient over the edge. So what else helps to keep those secretions thin in the first place? Adequate fluids and what? Turning? Turning. Okay, what else? Turning, coughing, deep breathing. If they're on O2, humidifying their O2. If they have a trach, making sure it's humidified. Because especially if they have a trach, what is the bypass? The upper airway, right? The nose and the mouth, which functions to do what? Warm the air and humidify the air. You're bypassing all of that. The air is very dry. So the trach collar is important to moisten, to keep the air moisturized, and to give them adequate fluids. It should, in many cases, prevent those secretions from becoming thick and tenacious.
Is that the bottle of water on the...
Yeah, the bubbler at the bedside, yes. Very important on trach patients. So if you have a trach patient and they have a trach collar on, make sure they have moisture that's going to, even if they're just breathing room air, but it needs to be humidified and warmed. A lot of them have little warmers on them. I think that's pretty much the highlights of respiratory. Any questions? So don't remember all of this just for a test. Remember it when you have to take care of your patient. I think that was it. Yep. So now your case study. We'll do that very quickly, and then I'll let you go. Oh, we better do it. Oh, we get out at 4:30, so we can do that case study in 15 minutes. So take out your case study. And you have a case study, the patient with COPD, correct?
Yes.
Who doesn't have one? Come and get one. Okay. Anybody else need one? Okay. How long did it take you to figure this out? An hour? And did you look in your book? Your text? All right. Very nice. Okay, so you have a patient with COPD, and the patient is Mr. Troy, right? He's a 61-year-old male, and in the morning report, when you come on for your shift, the night shift nurse tells you that he's been agitated during the night and he's dyspneic this morning. Okay, so just reading that, what are you thinking? What causes agitation? Lack of adequate oxygen going to the brain. Okay, so agitated and dyspneic. Dyspneic, how do you assess dyspnea? Subjective, so you ask the patient, are you short of breath, right? And there are objective findings as well. They look like they're using accessory muscles. The dyspnea itself is subjective. So O600 vital signs are temp 98.8, pulse 102, and respirations 32, blood pressure 146/98. Which ones of those are normal? The heart rate is tachycardic, right? The respiratory rhythm rate is called tachypnea. And the blood pressure is, he has hypertension. So you might have vital signs in a question, and it might have just a medical term. Patient is tachypnic, bradypnic, is eupnic. You need to just, based on what the description is of the patient, figure out what those medical terms are. At 0700, his pulse ox reading was 89% of room air. What do you want pulse oximetry to be? 93. But what kind of patient is this? COPD. They may not be able to get it up to 93. Okay, but that's certainly our goal. And he has an aminophylline drip infusing at 6 milligrams per hour per controller, per IV pump, and O2 at 2 liters per nasal cannula. He receives albuterol inhaler 2 puffs every 4 hours and Atrovent inhaler 2 puffs every 4 hours. He has a serum theophylline level drawn in the evening, and you get out a report at 7:30. So you need to prioritize the 5 nursing interventions as you would do them to initially take care of this patient who you just got report on. Before you ever go into the patient's room to care for them, in many hospitals you make rounds with the nurse, walking rounds, and you get report as you go see the patient. And you can then ask the patient, how was your night, or whatever. The nurse will tell you about that patient as well. When you get back, before you do the actual care, you need to do a number of things that we covered in first module. What do you need to have? Look at from the chart. Look at the lab. Today's lab. Don't look at yesterday's lab. Most patients in acute care have today's lab.
kind of code there?
You want to know if they're code or no code, so code status. So you're going to look quick look at their history and physical, look at their labs, print out the MAR, so you know what kind of meds to do at what time, and look at the most recent progress notes. If you look at the most recent progress notes, you will know what the focus is of the medical staff, the physician, in terms of the care of this patient. They will focus on particular problems that have been identified. Really helpful to get that clue. So now you've got report on this patient. How would you prioritize how to take care of this patient? Okay, when I read to you that the patient was dyspneic and was agitated, right? We also looked at the vital signs that are out of range of normal. His pulse ox was 89%, and he was anxious and restless. Those are all the things that you consider in setting your priorities. Those are deficits for the patient's care, your patient assessment, I should say. Okay, so if you know he's dyspneic, what comes to mind? What nursing intervention are you going to do when you get in that patient's room? Position him and set him up in high Fowlers. Very good. Okay, what else? Assess pulse ox. Okay, because it was pretty low. And what else are you going to assess? Reassess those vital signs and reassess those lung sounds. Absolutely. Did you look up those meds that the patient's on? Yes. Okay, good. Alrighty, so let's do those interventions first. What order did you put them in? 3, 2, 4, 5, 1, yes, and you can actually, as you're putting the patient in high Fowlers, check the O2 levels as well, or the pulse ox, especially if they're monitoring at the bedside. You can sort of multitask when you get to the bedside. So first, place them in high Fowlers, and then check the pulse oximetry. If they have a continuous monitoring at the bedside, you can just look at it, and you know what it is, right? So the third one, also take the lungs, and why are you doing that? To know what the baseline is at the beginning of your shift. And when you look at those vital signs, what is of concern to you? Respiratory rate and he's hypertensive, but a temp. What causes a temp? Infection. Okay. All right.
You don't have the temp yet, though, right? It's still 98.
98.8. Oh, I'm sorry. I was looking at the pulse, thinking it was a temp. Sorry. I misread it. Okay, so now, Mr. Troy, when you care for him, has the following signs and symptoms. He has a non-productive cough, long expiratory phase during respiration. Should the expiratory phase be longer or shorter than the inspiratory phase? Expiratory should be twice as long as inspiration, yes. He has increased shortness of breath with very mild exertion. What would you consider mild exertion? Getting up to go to the bathroom, or sitting at the bedside commode, or getting him up in the chair. Crackles audible throughout the bilateral lung field. What is the definition of crackles? Fluid in the alveoli. So those crackles are produced by air flowing through fluid. Okay, can you cough up crackles in the lungs? The fluid that's causing the crackles? No. Okay, he's anxious and restless. Anyone would be with a respiratory rate of 32 and an O2 stat of 89. And his theophylline level is 14 micrograms per milliliter. What's normal? 10 to 20. So theophylline level was okay. So now, after having all of these assessment findings, you have a list of all of the nursing diagnoses that are relative to this patient. So an ineffective breathing pattern. How do you know that? As evidenced by what ineffective breathing pattern, as well as with mild exertion. Yes, that one. Okay, ineffective airway clearance, as evidenced by non-productive cough. You're hearing crackles and maybe even rales, and he's not coughing productively. Risk for injury. He's restless and anxious and may not get adequate oxygenation, may become confused. Infection anxiety. Okay, infection is not a nursing diagnosis. So forget that one. Anxiety is related to difficulty breathing, as evidenced by he's anxious and restless, right? Anxiety. Impaired gas exchange, related to, what does he have? COPD. So the cause is related to fluid-filled alveoli, as evidenced by crackles. Where? Bilateral throughout. Activity intolerance, related to imbalance between oxygen supply and demand. When you have activity and you get really short of breath, there is not sufficient, the demand for oxygen is greater than what can be generated by this patient, as evidenced by increased shortness of breath with mild exertion. Activity intolerance, right? Mild exertion is activity. Risk for impaired skin integrity, related to it's risk for, hasn't happened, but why is he at risk for impaired skin integrity? Yeah, he doesn't have much activity tolerance, so he's probably going to stay pretty well put in the chair at the bedside or in the bed. So what are you going to do for that? Turn him frequently, and that turning will help his breathing as well. Okay? Altered nutrition, related to? No, that's a medical diagnosis. Yeah, shortness of breath, because he can't eat and breathe at the same time. And then as evidenced by, what lab would you look for altered nutrition? Albumin. Less than? Really severe malnutrition, 2.5. That a lot of labs would say less than 3.5, you're malnourished. Okay? Sexual dysfunction, if you're so short of breath, it's kind of hard to do any activity because he already has mild exertion. He has shortness of breath with mild exertion. I'm not sure why that would be in a hospital patient. We don't really make that a priority, but it's on this thing. So what's the highest priority? What will make his breathing better?
Breathing pattern.
So which one did you select? Who selected ineffective breathing pattern? Who selected ineffective airway clearance? Okay. Who selected activity intolerance or impaired gas exchange? Okay. The patient has all of those. The highest priority at this point is he has a non-productive cough, right? He has crackles audible throughout the bilateral lung field, so he has ineffective airway clearance. But he also has impaired gas exchange because his O2 stats are so low. But the highest priority, because he has that non-productive cough and everything else put together, for this patient I would use ineffective airway clearance. But he does have the others as well.
And in the module it said that was the number one priority for respiratory, was the anxiety with the gas exchange.
They do have anxiety, but it's not not a biological. You have to use a biological nursing diagnosis for your patient. So ineffective airway clearance, and why did you select that? What do you think has happened to this patient? What may have happened? He may have an obstruction due to a mucus plug. which will drop his O2 stats down pretty low pretty quickly. And that doesn't provide adequate O2 gas exchange, inhalation of the oxygen, use of the oxygen, and getting rid of the CO2. Yeah, mucus plugs can cause respiratory arrest, absolutely. So what are you going to do? To make this cough more productive, okay, turn cough and deep breathe, but what will make those secretions so he can cough them up? Increase the fluids and give him humidified O2, right? So humidified O2 and increased fluids, unless they're contraindicated. If they have underlying CHF, you wouldn't give them all those fluids. The heart wouldn't be able to compensate for all of that volume you give them. But unless it's contraindicated, you would give additional fluids. Push those fluids, turn cough and deep breathe. How often? Every 2 hours. Use the incentive spirometer every hour while awake, 5 to 10 times. What else? What would you monitor? Pulse ox, how often? Every 2 hours, okay. Or depending on the status of the patient, it might be routinely done every 4 hours. It depends on your patient. You determine the frequency and how stable the patient is. Okay. So at 12 o'clock, the patient care assistant reports that Mr. Troy is very warm and that his vital signs are now temp 102, pulse 98, respiration 32, BP 140 over 84, and he's expectorating thick yellow-colored sputum. What did you learn about the thick yellow-colored stuff? What is that often in the patient? Okay. Bacterial pneumonia, right? Thick yellow-colored stuff. Okay, so based on the 12 o'clock situation, identify and write the priority problem in the box below. Then, starting with the small box labeled number 1, prioritize the nursing interventions for the situation and identify your follow-up action for Mr. Troy. So, number 1, what are you going to do first? He said call the doctor. Yes, why? Yes, it's a change in status. You didn't have a temp before. Status change.
We discussed about that.
Yeah?
You want to get all the readings before calling the doctor?
No. Yeah, you do. Cooling measures need an order.
What about cooling off the
Yes.
Really?
Yes.
Cooling off the blanket.
You know, you're going to end up doing all of these things. So you're just asked to prioritize. I agree. I'm not going to argue what you're going to do first. But ideally, you would now inform the physician that the patient now has a fever. What was the temp earlier? 98.8. Normal, right? Now it's 102. Change in status. You must notify the physician. And, I'm sorry? That's significant in 4 hours. Absolutely. So change in status.
But wouldn't you administer the antipyretic and then call the doctor as a
But it says yes, we don't know.
If ordered. Yeah, I would certainly give that at the same time, if not, but I would notify the physician, give the antipyretic if ordered. Absolutely, that would be the second thing. Okay, what would you do next?
Well, if the doctor gives you an order, then
You have to list the ones that you have here. You can't add that the physician orders stuff.
Okay.
Using only what you have here. So you inform the physician or the charge nurse. You as a student would inform the nurse who's caring for the patient. And then you would administer antipyretic if ordered to see if we can get that temp down. The next one we're going to check O2 stats. Yes. Okay. What's next? Number 4? Yeah, you're going to auscultate lung sounds. And then next, provide cooling measures. And the last one, retake vital signs in 2 hours. If you have the patient with an elevated temp, depending on how high it is, you take the temp every 2 hours. That's a standard nursing measure. Okay, so what's his new problem? He has a fever. What do you probably think he has? Probably has an infection, probably a pneumonia of some sort, because he's expectorating that thick yellow sputum. Okay, well, hopefully you enjoyed doing this case study, putting it all together. I have another case study. You want to practice another case study? Yeah? This is a patient with a chest tube. Which one's yours?
Hello.
This one?
Which one's yours?